In this video, I'll share with you the 6 most common styles of MS doctors. Not style like you're a sharp dresser, but the style of how the doctor applies medicines to take care of people with MS, or the sequence of how they use MS medicines to care for you. If you'd like to better understand and decode your doctor's own style, don't turn away, because that learning starts right now. Howdy! Thanks for learning about MS with me, Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. Today's topic is decoding doctor's style, to better understand the 6 most common styles that doctors use when sequencing MS medicines. So let's jump in. Part of the reason I wanted to make this video is style of sequencing is very germane to how a doctor takes care of you, and yet it's not discussed. If your doctor has a style which doesn't fit with your goals, then that's an issue. And it's not something that I commonly see doctors and patients talking about. In fact, given that styles of sequencing isn't really taught to docs in med school, many doctors are not fully aware of how they choose to treat. It's my goal through this video that I can show you the 6 most common styles that MS doctors use. I hope that once I sensitize it to you, you can then identify what your doctor's style is. You can reflect on what style makes most sense to you, and hopefully it will spur on a conversation. The first style I'll talk about I call one and done. It's oftentimes where a doc has a preferred first-line agent, typically an injectable, and they put every single patient on that drug. Moreover, they don't really take the patient off. They could have an attack, they'll just treat the attack. They could have new spots on their MRI, they just reflect on it, or they may not even order an MRI. Rarely, if a patient's really not doing well, they may offer a referral to a tertiary care center or to an MS specialist. You may be listening to this thinking, that's crazy, people don't do that, but quite honestly, they do. There are still people who have a one and done style. Obviously, in the modern era, I think this is terribly inappropriate. The next style to discuss is called the stacker. Stacking is where you would start someone on a low efficacy MS medicine. And if they have breakthrough disease, for example, an attack or new spots on an MRI, then the doctor stacks a second medicine on top of it. This isn't done very much anymore in the United States. It was much more common 10, 15 years ago. There are other fields where stacking is done very commonly. For example, in oncology, it's very normal to stack multiple oncologic agents or chemotherapeutic agents on top of one another. This is done frequently in rheumatology, and it's certainly done very frequently in infectious disease. There has been some research in MS looking at stacking medicines together, and it hasn't panned out to date. It's extremely expensive to stack MS medicines, and also the safety concerns really make a lot of MS docs shy away. So this isn't a style that I see used much anymore. However, I predict that in the future we'll revisit it. Here's why. Presently, almost all of the MS medicines that we use are essentially anti-inflammatory medicines. They quell inflammation in the brain and spinal cord. In order to really beat this disease, I predict we need 3 kinds of medicines. We need an anti-inflammatory. We also need a neuroprotective agent, which doesn't exist yet. And we need a remyelinating agent that doesn't exist yet. So I predict that in the future, we will stack an anti-inflammatory, a neuroprotective, and a remyelinating agent together. Let's see if I'm right. The next 2 styles I'll discuss are variations on escalation models. The escalation model works like this. We'll start the person on a medicine that's considered lower efficacy, but very safe and tolerated. And if they do well, then we'll keep them on that drug. And the idea there is that's the best risk benefit for them. If, however, they have breakthrough disease and it doesn't work out, then we'll escalate to a second drug that works better in efficacy but might not be as well tolerated or not as safe. And then we'll monitor them on that second drug. If things go well there, grand. But if things don't work out, then we can escalate again to an even more effective drug that might be less safe or less tolerated. Theoretically, this is matching the disease needs to the risk benefit of a given medicine, and I really disagree with this model quite a bit. I'll throw a link up here to a video I did where I talk about why I don't like escalation. But let me share a little bit with you now. The escalation model is flawed. When you say we'll keep you on it unless something doesn't work out, what does something doesn't work out really mean? It means that we allowed you to be undertreated in your disease, and we allowed you to have breakthrough disease, which can cause permanent brain damage or spinal cord damage. In other words, we have to allow you to suffer brain damage before we put you on something more effective, as opposed to trying to prevent it altogether. Also, we don't have a complete capture of disease activity. The patient isn't always aware of some of the invisible damage that's being done. The doctor might not always catch it because they're not getting an MRI, or at least not seeing it often enough, or it's not showing up on the MRI, or their exam isn't sensitive enough to pick it up. Moreover, even when someone's feeling good early on in their disease, they can accrue a lot of neurological damage, which will play out and make them disabled 15 years later. A good example of this is brain volume loss or brain shrinkage. A lot of the injectable first-line drugs do a bad job of slowing brain volume loss, and they allow patients with MS to have accelerated rates of brain shrinking. That's not going to cause a problem at that moment, but it's going to cause a really big problem down the line. Obviously, I have a strong opinion, and I don't like the escalation model, but it's very commonly used. And so I'm going to share with you two forms of escalation that I see in practice. So the first style is the slow escalator. This is someone who starts off the patient on a low efficacy medicine, and it takes a tremendous amount of disease activity before they'll escalate. So they start them off on a shot, and they may wait until the patient has 2, 3, 4 attacks before they say enough is enough. Or they may allow multiple MRIs to have new lesions before they say enough is enough. They're a slow escalator. The second escalation style I call a fast escalator. And the idea here is we'll start the patient on a low efficacy drug, but as soon as we see disease activity, well, then we escalate. So they might escalate after only one attack, or they may escalate after only one new spot on MRI. Interestingly, most MS neurologists in the United States would probably qualify themselves as being fast escalators, although I'm not always sure they're actually doing that. The next style I'll discuss, to me, makes a lot more sense as compared to escalation, and it's the early application of highly effective medicines. Instead of escalating up, wasting time, and allowing breakthrough disease and brain damage, we start the patient off on the most effective therapy that they're comfortable with. We're starting them on the best that we have because we're going to control their disease the very best. Some people say, well, what do you do if that doesn't work out? Well, in 2019, we have 3, if not 4, highly effective medicines. And so if there were to be breakthrough disease on one of these highly effective medicines, we can change and pick another highly effective medicine. Obviously, you can tell this is a style that I really get behind. The next style to discuss is called induction, and frankly, it's one of my favorites. The idea here is when you start to treat the disease, you try to reboot the system. You try to change the immune response to change the trajectory of the disease long term. Ideally, you'd like to create a durable effect in the absence of ongoing treatment. This is done very commonly in oncology, and it's also done in rheumatology. It can be done in MS, but it's a minority of treaters that use this style. There are older drugs like mitoxantrone and Cytoxan, which were used for this purpose. There are also newer drugs like Mavenclad and Lemtrada that work to induce the immune response or reboot the immune response. This is a style that I think should be considered much more often. Just my 2 cents. The next style I'll refer to as stoppers. A doctor has placed a patient on a medicine, and they may have used any of the styles that I've reviewed so far. But then when the patient reaches a certain chronologic age, they think, well, the disease is no longer active, they don't have attacks anymore, so we're just going to stop their therapy. Theoretically, they're helping with the risk-benefit, with the theory that the drug's no longer really benefiting the patient and they can prevent risk by taking them off. And I think that's completely crazy and insane. This is something that has not adequately been studied. And in the studies that have been done thus far, a percentage of patients taken off drug go on to get worse. I'm not okay with that. And this is a style that I hope goes away. Now, whereas The stopper style is something that really bothers me. This next style makes a lot of sense to me, and it's the concept of de-escalation. I have done a video on de-escalation, so I'll throw a link up there in case you want to hear me talk a lot about it. But in a nutshell, the idea would be to hit the disease really, really hard up front with very high efficacy medicines. And as the patient moves forward in time, as they age, when they reach the second half of the disease, we don't need to use as high of an efficacy medicine. We're not stopping completely, we're de-escalating to a drug that's sort of used as a maintenance. I actually believe that this is the future of treating MS, and it makes the most sense to me immunologically. Check out that video if you haven't seen it already. Question of the day. What's your doctor's style? I just went over the 7 most common styles. Which one do you think your doctor uses? Second question. What is your preferred style? Think about it. And if your doctor's style and your style aren't aligned, I hope you guys have a discussion. Thank you for learning about MS with me. If you'd like to hear more about philosophy of treatment, click this video playlist right there. YouTube thinks that you would love this video playlist right there. And if you haven't yet subscribed to my channel, please consider doing so by clicking that circle with my face in it. Go ahead, click my face. Until my next video or live stream, this is Aaron Boster saying take care.